This is Coronary Challenging Cases Competition semifinal. You're going to have two winners, top two winners after how many presentation? 1, 2, 3, 4, 5, 6, 7, 8. 8 presenters. The first presenter is not here, so we're going to just jump to the second. And the top winners, I'm not sure what CVI going to give him, but probably BMW 3 Series or a pen. I have no idea, but but it's really interesting. And the titles. When I'm gonna write something, I'm gonna call you guys to kind of choose my title. Really very catchy titles. I love them. So is Bassam Hennawy here? Not here yet. So Bassam Hennawy is supposed to give his talk case at 8:40, but if you are here, we can go ahead and start. Can we start with Bassam Hennawy? Are you here? All right. So Bassam Hennawy, the culprit dilemma in ACS. That's a really very good title. Where are you from, Bassam? Egypt. Oh my goodness, come on. All right, the podium is yours. Thank you. All right. So this is to advance, and this is to go back, and obviously they taped over this so you don't touch it. But so the green to go forward. If you have anything,
okay, sure.
The podium is yours.
First of all, I'm all pleased to present a case in this great event. It's a highly scientific one, and we all benefit from all the sessions. Our case today is about the culprit dilemma in ACS. Nothing to disclose about the case. Our patient is a 57-year-old male patient. He's a heavy smoker and works as a driver. He had uncontrolled diabetes for 10 years. He had a history of PCI 2 years ago to the right coronary artery, but he is not compliant on his medical treatment. He was presented to the ER by ACS. Our patient was oriented to time, place, and person. No special abnormalities in his vitals, although his blood pressure is 140/100. His chest examination was harsh vesicular breathing due to smoking, and cardiac examination only apical S4. His EKG showed dynamic T-wave changes while he was in the CCU in anterior leads, followed shortly by 1 millimeter ST segment elevation in leads 4, 5, and 6. So we entered the cath lab, and upon coronary angiography, this was our first loop. The LAD was totally occluded with heavy calcifications, and also the LCX, but it seemed more recent occlusion. And also the first sizable OM had a significant ostial lesion. And the right coronary gave collaterals to the LAD, but no significant lesions in it. Okay. So the most important question in the ACS is where's the culprit lesion? Because the patient had agonizing chest pain on table, and there was dynamic changes in the ECG in the anterior leads. So we stopped for a while to think what was the culprit lesion, and the LAD showed to be chronically occluded, but we weren't sure from this culprit or not. So we gave a try to the LAD, but it didn't open, and we were sure that it's a CTO and it's not the recent culprit, but the changes were mostly anterior changes. So we thought about another culprit which collateralized the LAD. The LCX showed to be the culprit because of the competitive flow. This the LAD trials, it didn't succeed. So the LAD is collateralized, and the LCX showed to be recently occluded. So we wired the LCX and the sizable OM. The sizable OM had the tight ostial lesion, and we ballooned the LCX, the total occlusion first. Then we had some flow, but we should refer to a bifurcational PCI due to the sizable OM and the ostial lesion. This is the image after the PTCA. And then another decision was what to do as the best strategy for this bifurcational lesion. The time is not in our favor. So we decided to do the fastest strategy, to do a rapid tap technique. And we began with the OM as the main vessel. Okay, and then they tap to the LCX at the side branch. Encasing balloons. And this is the final result of the bifurcation. We noticed some haziness in the distal LCX stent. So we reassessed in a cranial view, and we realized that there is an edge dissection. This is a pot for the LCX stent. And then we put another distal stent to cover the dissection. And all was fine at the end with TEMI3 flow. The LAD lesion was scheduled to be done in another session after the patient recovered from the ACS. And the chest pain improved dramatically with normalization of the EKG just after the PCI. Our key learnings from this case was to differentiate the CTO from recent vessel occlusion. This is of utmost importance, especially in the ACS session. And if bifurcation stenting is inevitable during an ACS, choose the technique with the least time, and you are best at assessing distal LCX stents in cranial views is sometimes crucially important because the distal LCX in the caudal views cannot be assessed properly in many times. Thank you so much.
Perfect. So can you summarize to us, like, yeah, obviously the operator touched the LAD with the wire and figured that out. And I'm not sure if you showed the EKG. Did the EKG was more lateral or mainly anterior changes?
Starting from V4 to V6.
V4 to V6.
Yeah.
And how about one in AVL?
No, there was only T-wave changes, but we're not such dynamic.
Okay. All right. So any questions for the contestant from the panels?
I mean, I think that one of the things when you're unsure what the culprit is, you could always do an LV gram. In this scenario, it may have helped if you saw like an aneurysmal anterior wall or something like that. But yeah, you didn't waste too much time, which is good, and just poke at the LAD and move on. And in an ACS setting, or really in a STEMI setting, I try to avoid bifurcation stenting if I can. There tends to be a lot of thrombus burden. Also, intravascular imaging may have helped avoid that distal edge dissection.
Yeah.
I think another way to help sort out the chronicity of the LAD is to look at your collateralization as well. So if you have extremely robust collaterals coming from the RCA, or there's multiple areas that are collateralizing it, that can be another hint, of course, that it's a bit more of a chronic lesion. So.
Okay.
Yeah, one quick thing. I agree with that. When a patient comes in looking like a STEMI, usually without ST elevations on the EKG, it's almost always a circumflex that's silent by EKG. And I agree with Mitul, the stenting here. I mean, you had great result, and your points are well taken that you should go with whatever is simplest and you know best. But the simplest in my mind is just provisional stenting. I would have just stented down into the occluded OM, and the other one was patent. You could always, it's probably going to stay patent. You can always deal with it after the fact.
Kevin? So any questions from the audience for the contestant? All right, so Kevin, you want to present the next, my co-moderator, you want to present the next, thank you so much.
Thanks very much. Next up is Dr. Simeon Villangca. a case of coronary artery dissection and perforation, a severe 3-vessel coronary artery disease with chronic total occlusion. Welcome.
Okay. So good morning. I'm Simeon, the Villangca, an adult cardiologist from St. Luke's, Quezon City, Philippines, and I'm here to present my case during my fellowship training, a case of coronary artery dissection and perforation in severe 3-vessel coronary artery disease with chronic total occlusion. So I have no financial disclosures. So to start, this is a case of a 67-year-old male, hypertensive diabetic, asymptomatic, non-smoker, non-alcoholic drinker, and the physical examination is unremarkable. The resting echocardiogram is normal, but there is an abnormal stress test with a low workload at 5 meds. So the patient is for elective coronary angiogram. So this is the coronary angiogram done to the patient. The images on the left show the left coronary system in the RAO caudal and RAO cranial view. And the LAD is a type 3 vessel with severe stenosis at the proximal segment. The LCX is a diffusely diseased vessel with a mild stenosis at the early proximal segment and moderate stenosis at the late proximal segment. There is also severe stenosis at the mid and moderate stenosis at the proximal segment of the OM3. On the right is the LAO view of the RCA showing a total occlusion at the late proximal segment. The near total occlusion and a total occlusion at the early mid segment. So the distal vessels are visualized via intracoronary and intercoronary vessels. So for the PCI of the LAD, a balloon predilatation of the proximal to early mid segment was done using a Sapphire 2 Pro 2.5 by 15 millimeter balloon inflated multiple times at a maximum of 18 atmosphere. So a resolute onyx drug-eluting stent was then positioned at the proximal to early mid segment and deployed at 14 atmospheres. So an NC for a 3.5 by 12 millimeter drug-eluting balloon was used to post-dilate the stent and inflated multiple times at a maximum pressure of 24 atmospheres. So upon contrast injection after the post-dilation of deployed stent showed a type B dissection located at the edge of the distal end of the stent with no contrast leakage. So a stent overlap was done with the resolute onyx 2.5 by 12 millimeter drug-eluting stent positioned at the mid-segment overlapping the edge of the previous stent and deployed at 13 atmospheres. Post-dilation of the stents was done using the stent balloon. So for the final angiographic image of the LAD, it showed well-apposed stents with no residual stenosis and T3 flow up to the distal runoff with no evidence of perforation and dissection. So for the PCI of the RCA, an Nasahi intake filter XTR was then advanced to the RCA, successfully crossing the near total occlusion at the late proximal segment. Multiple attempts was done to cross the total occlusion at the early mid segment, but without success. So a Nasahi intake Miracle 6 coronary wire was then advancing to the RCA up to the totally occluded segment, successfully crossing the lesion. Its tip was parked at the distal end of the RCA. There was difficulty to advance the NC balloon. Guide silo was used at the same time and filter XTR was removed. There is noted leakage of the contrast at the mid segment consistent with the type 3 coronary artery perforation. So the balloon tamponade was done using a Sapphire 2 Pro 2 by 18 balloon inflated at 16 atmospheres at the mid segment for 7 minutes. And on repeat contrast injection, after deflation of the balloon, it showed no evidence of the contrast leak. So the Miracle 6 coronary wire was then exchanged with the cyan blue and via the balloon trapping method using the Sapphire 2 Pro 3 by 15 balloon. And balloon predilation of the distal to proximal segment was then done using the Sapphire 2 NC 2 by 18 balloon. So a stent was placed, Synergy 2.5 by 48 drug-eluting stent was positioned at the mid to distal segment, and post-dilation was done using the stent balloon. Also another Synergy 3.5 by 48 millimeter drug-eluting stent was positioned at the proximal to mid-segment and post-dilated with the stent balloon. So for the final angiographic image of the RCA, it showed well the post-stents with TIMI3 flow up to the distal runoff with no evidence of perforation and dissection. So for my take-home message, coronary artery perforation and dissections are rare but one of the life-threatening complications of PCI. Several risk factors increases the risk of those complications. Immediate recognition is key to early management, and for this case, overlapping stent in the dissection and prolonged balloon inflation in the perforation controlled further progression. So appropriate management is life-saving. Thank you.
Perfect, thank you. That's interesting case. Let me ask you just a few questions. So is that all performed in one single session, like the LED, the CIRC, and the RCA?
Yes, sir.
Oh, okay. Is there any pressures where you practice to kind of complete the revascularization in the same session, or do you stage these cases? Like one of the things we do in CTO, never do ad hoc CTO. Always do it in a separate session, because that always kind of increases your success rate. But some situation when, like I have patients who come, they don't have insurance. And if they leave the hospital, they're not going to come back electively. So I will actually open all their arteries while they are in the hospital, because I know they're not going to come back if they leave. Is there any such in your healthcare system? Is there such pressure, or you just chose kind of you guys kind of, because he's symptomatic, you chose to kind of perform complete revascularization?
For this patient, he comes in asymptomatic. So, but the attending physician opted to do the whole procedure in one set.
Oh, okay. All right. And panelists, any questions for the contestant?
Go ahead. Yeah, it's just it's a nice example of you don't always have to put a covered stent in. In the U.S. and I think in Canada and hopefully elsewhere, we've got these new balloons called Ringer, which many of us have had a chance to use. It's a perfusion balloon where it goes up as a ring. You can leave it up for a while and the artery still perfuses. So eventually when we have problems like this, it'll help to manage it.
Just one comment and a question. Again, that LAD looked pretty calcified. I think intravascular imaging, I don't know if you just didn't show that or if that was done could have been very helpful. And you had two different stent platforms, LAD and right. Was that just for sizing or length availability?
For this case, the operator did not use any intravascular imaging prior to the.
So let me ask you this. So a patient comes with acute presentation and you dilate it, like what the reason to dilate with 2.5 millimeter balloon and then put 3.0 stents? How did you ensure that your lesion actually expanded in a proximal LAD? Because it could expand to 2.5 millimeter balloon, right? But when you put the stent, it could end up in hourglass.
For this case, I think it's ideal to use an intravascular imaging to supplement the high pressures for the stent.
Yeah, just for the audience, it's like we used to do that. You go 2.5 millimeter balloon, a proximal LAD. You have to remember, proximal LAD, God does not make it 2.5 millimeter. It's definitely 3.0, 3.5, or 4.0 most of the time. And if you put an IVUS, you'll discover it's 4.5. So if you go with a 2.5 millimeter and then go with a stent, you have to demonstrate, either you have to demonstrate by intravascular imaging, which might not be available. I know the country of Syria, for example, they don't have IVUS. So I'm not sure about you guys in Philippines, but, or what you can do, just kind of feel it with a regular size balloon. Like I will go 3.0 balloon and go 3.5 balloon before I put a stent with 3.5. If you achieve 3.5 millimeter diameter, I think that's adequate. Just kind of feel it. Any questions from the audience to the contestant? All right, thank you so much. We really appreciate you presenting.
Thank you.
Okay. All right, the next contestant, I can't read it. Let me just put my glasses. Sorry, guys. That's what goes with seniority. Dr. Rafik Ibrahem, he's going to present very catchy. Syncope, is it your head or your heart? Normally, 75% of the time is the cardiovascular system, right? Okay, good. Let's see it.
Good morning, everybody. This is this is Rafik Ibrahem, interventional cardiologist from Sohag, Egypt. It's my pleasure to present my case today in this great event. My case is about syncope. Is it your head or your heart? I have no disclosures. My patient was 69 years old male patient, heavy smoker with impaired glucose tolerance, on metformin, not hypertensive. He presented 2 hours after a brief syncope with no chest pain during or after the attack. ECG showed inverted T wave in lead 3 and sinus bradycardia. Blood pressure was 110/70 and pulse was 48 beats per minute, sinus rhythm. Enzymes were negative and echo showed diastolic dysfunction grade 1 and mild mitral regurgitation. CT brain was free and oxygen was 96% on room air. How to evaluate this patient? First, whether the event is transient loss of consciousness or not. And in case of transient loss of consciousness, is it of syncopal or non-syncopal origin? In case of suspected syncope, if there is a clear etiological diagnosis, and if there is evidence to suggest high-risk cardiovascular events or death. The syncope in the context of transient loss of consciousness, according to the European Society of Cardiology, is classified into non-traumatic and traumatic causes. The non-traumatic category also is subdivided into other 4 groups: syncope, epileptic seizure, psychogenic, and other rare causes. The management of patient presented to ER with transient loss of consciousness, we have to start with the symptom of the patient. Is the syncope the predominant symptom or not? If no, syncope is one of the symptoms of an acute principal disease. You have to care pathway of the principal disease. But if yes, so if there is a clear or unclear diagnosis. If the diagnosis is certain or high likely, you should manage the appropriate therapy for this disease. If no clear diagnosis up to now, you have to follow the risk stratification flow chart. We have to assess the syncope event and the past medical history and physical examination of the patient, searching for any high-risk sign of the patient. Back to our patient, if there is any high-risk signs, yes. If there was no warning symptoms before the syncope attack, and the patient still have sinus bradycardia, 40 to 50 beats per minute, in the absence of negatively chronotropic medications. So we admit the patient under observation. Follow-up ECG showed no changes, but follow-up cardiac enzymes 6 hours later were positive, so we transferred the patient for cath lab for coronary angiography. The left coronary system was atherosclerotic with no significant lesions, but the surprise was in the right coronary system that is totally occluded RCA with high thrombus burden. At this point, I double-checked the patient again, asking for any chest pain, and he completely denied any chest pain. We proceed with angioplasty. Judkin Wright 3.5 guiding catheter through femoral axis used to cannulate the RCA, and run through wire across the mid-segment total occlusion with intracoronary glycoprotein 2B3 inhibitor administered with some improvement in the thrombus burden. Direct stenting failed due to tight mid-segment stenosis, so we used a short balloon 2x12 to dilate the mid-segment severe stenosis with significant improvement in TIMI flow. Then DES 3x38 was deployed at the mid-segment RCA with very good final result. Later on, during follow-up at CCU, the patient heart rate increased up to 64 beats per minute. My take-home message. Syncope is defined as transient loss of consciousness due to cerebral hypoperfusion, characterized by rapid onset, short duration, and spontaneous complete recovery. The causes of syncope are numerous, but life-threatening conditions should be identified as the first priority in order to avoid catastrophic outcomes. Syncope may be the sole manifestation of silent RV infarction, even in the absence of typical symptoms of acute coronary syndrome or hemodynamic instability. Continuous ECG monitoring and prolonged ER observation in a syncope patient without immediately identifiable causes is warranted to avoid such potentially life-threatening conditions. Thank you.
Perfect. You are actually gained 37 seconds. That's awesome. So let me ask you this. The troponin was negative at the beginning?
First set, yeah.
First set?
Yeah.
Okay. So it is the syncope, it's the heart, not the brain, not the head.
In this case, it's the heart.
That's good. I want to ask a question about your technique in the RCA, because this is an interventional meeting. So what the rationale for direct stenting in this patient?
Actually, because of high thrombus burden, I was afraid of no reflow.
Okay.
That's why I prefer to do direct stenting.
All right. So, like direct stenting that will prevent, is there any studies that show direct stenting prevent no reflow?
No, but actually I think that multiple balloon inflations may increase the incidence of no reflow in acute settings.
Okay. All right. So, panelists, any questions for the contestant?
I see your concern here, but I think it's reasonable in STEMI to directly stent. Most of the time it's just a clot burden, there's not a lot of calcium, but if you feel like the stent is not going, which means there's a lesion, I would probably not choose a 2O balloon, maybe choose something bigger just to make sure I prep the vessel well before you put a stent and have a hourglass appearance to a stent afterwards.
Yeah, and I think it's also interesting that he didn't have ST elevations in his inferior leads and was completely asymptomatic from an angina perspective, even though he just had impaired glucose tolerance, was not like a long-term diabetic on insulin in that scenario.
Yes, actually, I admit the patient just for this unexplained bradycardia. And the plan was to check if there is any AV conduction block. That's maybe the most common cause. And if not, we will send the patient for Holter monitoring. But we checked the enzymes one time later, 6 hours after admission, and that's why we proceed in coronary angiography.
And is it your center's practice or your personal practice to use intracoronary 2B3A inhibitors, or was it just, do you do this in a high thrombus burden case usually?
In high thrombus burden case, I usually use it.
Okay.
So ultimately, of course, you found this RCA occlusion, but what do you think the mechanism of syncope was itself? Do you think they went into high-grade AV block or hypotension, or any theories around that? Or
I think the patient may experience paroxysmal heart block during the thrombus formation, and then maybe revascularized, or I don't know, but actually I think it's ischemic induced. That's why he syncope just for a few seconds.
So syncope were normally arrhythmia, right? So either bradyarrhythmia or tachyarrhythmia. Yes. So he's occluded the RCA. Either he went in a VFib, VTAC, and got out of it, or just became bradycardic, or which is the most common in the RCA. But you mentioned that it's RV infarction, silent RV infarction. Why did you? How did you diagnose silent RV infarction? Did you do right-sided, or did you do right heart catheterization?
No, I did not.
Okay.
Just one of the causes of.
No, it makes sense. He could have RV infarction because he has a prox RCA occlusion, and that actually could be RV infarction. But the syncope normally is related to arrhythmia, and RV infarction will cause cardiogenic shock. And basically, I'm not sure syncope is the final thing for RV infarction. Any questions from the audience to the contestant? Perfect. Thank you so much for presenting interesting case. Thanks.
Yeah, next up we have Dr. Mina Youssef with Series of Unfortunate Events. Welcome.
Good morning. It's a pleasure to present in this meeting. I'm Mina Youssef from Cairo, Egypt. I will try to summarize a story of 7 hours in 5 minutes. I have nothing to disclose. So we have a 67-year-old male patient. He is a chronic heavy smoker, hypertensive, on valsartan amlodipine. He is not known to be diabetic. He presented to our ER with typical chest pain of 6 hours duration. His ECG showed LVH with non-specific STT wave changes. His echo showed an ejection fraction of 35 with regional wall motion abnormalities across the LAD territory. His labs showed rising troponin, so we made a diagnosis of in-STEMI. The plan was early invasive strategy in the next morning. So this is his diagnostic coronary angio. We have a bifurcation mid-LAD, Medina 111, involving the LAD and the ostium of the diagonal. A PT2 MS wire was used to cross the subtotal lesion in the LAD. While trying to cross the diagonal, we lost the flow in the diagonal branch. I pre-dilated the LAD. I have a problem. Okay. I pre-dilated the LAD, then the diagonal opened. After this, I did pre-dilatation to the diagonal branch. The plan was to go with stenting of the LAD and check the diagonal later. Actually, this diagonal was lost, and after the LAD stent, there was what we can see as an edge dissection. The plan was to recanalate the diagonal and check the distal part of the stent. With our attempts to enter the diagonal, as you see, a big thrombus formed from the ostium of the left main down to the LAD. And at this part, the patient was crashing in severe agonizing pain. I didn't have aspiration thrombectomy in the cath lab. So I went with a 4x48 drug-coated drug-eluting stent overlapping with the mid-LAD to crush the thrombus formed in the left main. Then comes the next complication. The balloon of the stent failed to deflate. With all the attempts to rupture the balloon with the back of the wire, also it failed to deflate. I know you have to resist all your instincts to pull on the balloon, but this is what I did. I pulled on the balloon, and the balloon was cut, and the shaft was torn, and I am left with a balloon obstructing the left main. I succeeded to pass again with a wire cyan black. This time, I got a smaller balloon distal to the torn balloon. I inflated it to a lower pressure and pulled. If you see on the image on the right, the balloon of the stent started to come up in the aorta. At this time, I used the one snare. I pulled the balloon out of the coronary from the left main out of the patient, and this comes out. At this step, you think, oh, you have done the work. But here comes the surprise. After this distortion of the stent in the left main LAD and the LAD, the flow was very bad. So again, the wire inside the left system, smaller balloons moving to bigger balloons. And I had, again, to the left main. And this was the situation. Still the edge of the stent in the mid-LAD causing the edge dissection. I stented the mid-LAD with 2.75 by 28 stent. And here was the result. It was acceptable for us. However, there is a part of a hematoma in part of the stent, or what we think it was a hematoma. Then I flared the left main stent. And this was the result. At this time, we have spent literally 7 hours in the cath lab. We have used 400 cc's of dye. The patient was at this time stable. There was no chest pain. There was no heart failure or anything. So the plan was to take the patient to the CCU, give him medication for 1 week, follow up his creatinine, and after 1 week, we get him back to the cath lab and do an IVUS. Unfortunately, our cath lab is not equipped with IVUS all the week. We have to arrange to bring it. So the plan was to bring the IVUS after 1 week and to re-angio the patient to check the stents all through and to check the part of the what we think is a hematoma in the mid-LAD. However, after this near-death experience, the patient refused by all means to go into the cath lab again. He told me, whatever you say, whatever you do, I'm not going to the cath lab again. I saw this patient 2 months ago to renew his medications. I asked him if he's interested to go back to the cath lab to try to figure out what is going with his coroners at this time, but he told me, no, I will not do this experience again. I will die when God wants me to die. So my key learning points, when dealing with bifurcation that will need a two-stent strategy, plan this ahead and do not take the easier way of provisional stenting. Always follow up your ACT with the patient in long procedures to avoid acute thrombosis. When the balloon fails to deflate, resist all your instincts to pull, because pulling will not solve the problem. Try to think of other things to get it out. A cath lab must be equipped with all instruments to deal with complications. Thank you.
How is the patient doing hemodynamically with the obstructing balloon in the left main?
How was the patient at this time?
Yeah, blood pressure, heart rate.
The blood pressure was down, but the patient was, actually when the LAD closed in the beginning, the patient did not have much of chest pain. But when this balloon failed to deflate, the patient was crashing, he was holding his chest, blood pressure went down, everything in the cath lab was a mess. Even trying the back of the wire, I didn't do much because I didn't want to make more complications by perforation or something, but I don't know how, when I pulled the system and all the system and the balloon got torn, for somehow the balloon deflated and the patient was not in that agony with the balloon obstructing the flow.
Great. Do you have Impella or ECMO or any of the bailout things that you
No,
could use?
we don't have this in our center, unfortunately.
It's nice you were able to get through it without those.
Yes.
I imagine you were giving pressors like epinephrine and things to keep the blood pressure up while
yes,
working.
Yes, that's what we did.
Excellent. There is discussion of one thing that can help to get a balloon which is inflated to deflate. If you cut the back off of the hub of the balloon, if you have guide liners, you can shove it down on top of the balloon, pull on the balloon, push on the guide liner, and then take the back end of a stiff wire and try to poke it. It just sort of keeps the wire pointed at the balloon. That's one little trick. It's a particularly unfortunate place for this to happen, and I commend you for getting this stuff out. And it's unfortunate he doesn't want to come back. I would wonder about what is up with the mid-LED. I think you plan to IVIS it when the technology
yes,
would be available.
I'm interested up till now to see what's happening in this mid-LED.
Yeah, because it was an area where the stents overlapped one another,
yes.
right? So I would think it'd be under expansion, plaque prolapse, or thrombus prolapse would be the main things that would lead to that.
I thought of this, and I didn't show the images. I did an NC balloon to this part multiple times with no success. So I didn't want to make things worse and stopped at this part.
And you mean by no success is the balloons didn't expand, or you continued to have that haziness in the stent?
It expanded, but I continue to have this part that it's not fully expanded in the angio.
Yeah, sometimes when I've had hazy stents like that, and we've been able to do OCT, I think you will find a peri-stent dissection with intramural hematoma, and the lumen actually looks okay. So sometimes you can defer these things, especially in an area where you had the stent to cover a previous dissection. So,
yes,
all good points. Thank you.
Thank you.
Well, what will you guys do? It's a great case. I'm fascinated. What do you guys do? I just kind of for when deploy the stent and you have this. So what works now? Do you like this patient? Obviously had to go to the CICU and issue. Would you use cutting balloon, laser? Would you go back and ablate it? What kind of strategies would you guys use?
Well, I think it depends on what's going on. You know, I mean, we have, and you did a fantastic job with very limited resources, and I think we all commend you, and none of us want to be in that situation ever with an inflated balloon in the left main. But yeah, I think, you know, the theme with all of these cases so far is intravascular imaging would have probably prevented a lot of these situations, but then you wouldn't get to present it here, so it's a double-edged sword. But yeah, it really depends on what's going on. If it's, like Kevin says, if it's a hematoma, you leave it alone, walk away. If it's calcium that's preventing it, then maybe you do off-label post-stenting shockwave or something like that if you have access to that. But it really depends on what you're dealing with.
Yeah, I would tend to agree with that. I think using imaging to actually sort out what's going on is going to direct your management. But those are tough situations sometimes where you see this bit of tissue protrusion, for instance. I don't have laser at my center, so I mean, I've used cutting balloons sometimes. I have drug-coated balloons, but really that's just going to press it up against the edges kind of thing. So sometimes I just have to leave it as well if everything's well expanded and, you know, I've tried to modify it the best I can, and it's a bit of tissue. It's hard to know what's the right thing to do with that. There's a potential to put another layer of stent as well, but I don't know if there's evidence to support that that's really changing the situation. The only other thing I was going to say is that in general, when the thrombus formed in the vessel, you know, I don't know what you do have available. Do you have aspiration
No, I said
thrombectomy?
at this time we do not have, I didn't have in the cath lab aspiration.
Okay.
I tried to aspirate from the main catheter several times, but it didn't work.
Okay, fair enough.
Yeah, if you're, you know, intravascular imaging, and if you see deep calcium, I've started using a lot more, you know, lithotripsy for those cases. And what did you use heparin or bivalve? I'm assuming.
Sorry?
For your anticoagulation. What was the anticoagulation?
Heparin.
It was heparin.
Actually, the problem in this patient was that the cannula, I discovered this retrograde. The cannula was out, and when they give heparin, the patient didn't have any pain, so we assumed it goes in. But after this thrombus formed, I started to follow up the ACT. I give heparin in the cannula, and the ACT do not go up.
Oh, wow.
Until I told them, no, I want the heparin in the sheath. I gave the heparin in the sheath, and the ACT went up. So that was the problem for the thrombus.
Wow.
I mean, that's a very good point. Especially in complex cases, I would not start before I make sure that the ACT is high. And you may want to give huge doses of heparin, or if you in Angiomax and you know that the ACT is going to be high, I check it just to make sure that it's going inside the patient, or give it through the sheath. That's very important. I would have done the same thing you did. I mean, you did the right thing in this procedure. And I would not necessarily bring the patient back. I mean, I agree with him that I don't want to come back to the lab. You could always do stress tests and things. He's doing fine. Just, well, I wouldn't go back in.
Know.
Did you call the surgeons?
At some point, in the beginning, the passing of the wire, the Simeon black, after we got out the balloon, this was not easy. The metals was crumbled.
Yeah.
At this time, I called the doctor that was assisting me to call the surgeons and make them ready. At any time, we will transfer the patient for bypass.
Okay.
And they were ready, but fortunately, we didn't need them.
So he lost a large diagonal.
Yes.
And sometimes what I do in this situation, if I lost a branch, and you can go back and shoot the RCA, you might discover like there are collaterals there. So how high was his troponin after the procedure?
After the procedures, it was like 2 times higher than before,
Okay, so he got an MI from that diagonal. Yes. All right, so thank you so much. I really appreciate it. This is a fascinating case. And
the patient was diabetic, yes.
So why not surgery to start with?
It was single vessel disease, non-STEMI.
So in diabetic, LAD bifurcation lesion, diffuse disease, so this was a better treatment?
It was just a focal bifurcation mid-LAD with diagonal.
So the FREEDOM trial, it's 87% of the patient in the FREEDOM trial. The FREEDOM trial showed that the cabbage is better than PCI in patient with diabetes. However, it was triple vessel disease or 2 vessel disease, and 87% of those patients enrolled in the FREEDOM trial had 3 vessel disease. This is a single vessel disease. I think most cath labs, at least here, will proceed with PCI in a STEMI patient. But if a 3 vessel disease, I'm with you in that situation that probably. And this bifurcation is Medina 111, so it should have been actually 2-stent strategy from the get-go. You should never you should plan it. And I did a few cases in the Middle East. Amazingly, they have a lot of plaque, but no calcium. So all patients in the Middle East, not like us here. So a lot of plaque. Like this is very heavy plaque burden. Oh, thank you so much.
Thank you.
All right. All right. The next, a perfect 10, complete revascularization by Rahul Potluri. Rahul?
Hi. Hi, good morning. My name's Rahul Potluri. Thank you for accepting this case. I work in the United Kingdom where the healthcare system is slightly different, but I have worked in Canada as well. I wanted to talk to you about complete revascularization in this case, and this happened early on in my consultant career. So the case is a 86-year-old male admitted with acute coronary syndrome and STEMI, had background history of AAA, hypertension, COPD, and mild Parkinson's, had an active lifestyle, cared for his wife who had advanced dementia. As I said, he was admitted with an end-STEMI. Global ECG changes were more prominent in the LAD territory. His echocardiogram showed mild LV impairment with an ejection fraction of 45 to 54% with some regional wall motion abnormality. Unfortunately, during the admission, his wife actually died, and he wanted to be discharged as soon as possible to plan the funeral, but he had ongoing chest pain. This was his coronary angiogram. As you can see, quite diffuse disease in a large dominant right coronary artery with some proximal disease as well. Very large PLVs and PDAs, as you can appreciate. And this is his left-sided system. So distal left main with some severe disease in his OM. And if you look at this image, you could see that the LAD is subtotally occluded with severe disease in diagonals as well. So it was quite fairly simple for me early on. There's a saying, so KISS, which is keep it simple, sir, or keep it simple, stupid. So made a CABG referral. Unfortunately for me, what happened, he had an MDT discussion, or your heart team discussion, as you say in the States. He was turned down for surgery, and patient also did not want surgery because the inpatient waiting list for bypass surgery in England is around 2 to 4 weeks, and he wanted to be discharged as soon as possible in view of his wife. So the discussion was between PCI and medical therapy. He had ongoing symptoms, so the decision was for PCI. There were a number of views as to which vessel you'd take on first, the right coronary artery, which is dominant, or the left coronary artery, and how much to treat in the left coronary artery was also a discussion. We felt that, well, I felt that the best option would be to treat the right coronary artery in the first instance, given that it was a slightly easier management option, and also if the left coronary artery was needed, we could use the right coronary artery if it was fully revascularized to give some support. So this is the right coronary artery, so wired the PLV branch and the PDA branch, and I decided to, given that there were fairly large branches, to kind of completely rebuild the PDA and treat the PLV branch and all build back, really. So 2 long stents in the PDA, as you can see here. And then the question was, what do I do? Do I then treat the PLV and then stent the distal RCA proximal PDA, or what next? So I then decided to treat the PLV branch with a stent, and then covered the proximal PDA and the distal RCA with a further stent. It looked very nice, except that obviously the oculostenotic reflex, the proximal part of the PLV branch, that looked like a little bit of an edge dissection, and I felt that it's probably not the right thing to do, to leave it. So I went back in and did a culotte of the proximal PLV branch back into the distal right coronary artery, and that was a KISS. And then treated the proximal RCA with a further stent, which also went very well with some post-dilatation. So this was the final result. So very large coronary artery with fully revasked, very, very good results, 6 stents at this stage. And I felt, okay, we do the job, he can go home, maybe manage the left coronary artery medically. As it happened, next day he was seen by a non-invasive consultant on the ward round and felt he's had ongoing symptoms, and unfortunately fell down to me again as I was on call that day. And the decision was for PCI to left main stem and LAD. So now what do we do? Well, we could just treat the left main and do a patchwork, or decide to go for full, complete revascularization. And at that point I thought, he tolerated the right coronary artery well, and there were some signs that actually the culprit was the LAD, and on repeat angiography at this point, it was felt that the LAD itself was quite tight. It was they had decreased flow compared to the diagnostic coronary angiogram. And if you can appreciate, you got those two large septals and almost a trifurcation, but the LAD itself is a small caliber vessel which I had to wire with the help of a Caravel microcatheter. I was not always certain where I was, so I went back to my fellowship teaching, used the lateral view to ensure that I was in the LAD, as you can see in this one. So then built back the LAD, pre-dilated. The question at this stage was if I'm going to treat the LAD, what do I do with the diagonals, which were actually quite big branches, and in fact bigger vessels than the LAD itself. So I decided to treat the diagonal first before I block off the access to the diagonal with a further stent in the LAD. So that went quite well, as you can see there. Thank God I left the earlier diagonal alone and then restented the mid-LAD with a further long stent, and at this point it was looking nice. So I thought, what should I do about this left main stem? What strategy should I employ? Well, DK Crush 5 was quite hot at that point, and I thought, okay, well, shall we do a DK Crush, because it's got the best evidence. So I went for it, and the patient was quite stable. So I treated the angulated branch first, which was the left circumflex. In my exuberance, I forgot to take an image of that stent in the left circumflex. So I treated the left circumflex, crushed it, and then rewired, and this is the first kiss, as you can see. And this is a long stent in the proximal LAD back into the left main, long 4-rows iron stent. And that went down quite well with the help of a guide liner. I did the second kiss, as you can see on the left. And this was the final result in the end. So all branches open, very good DK Crush result in the left main, LAD, left circumflex. And all branches open. At this point, it was 10 stents, so there's nothing left to do anymore. So I'm not going to bore you with this because I know that you are all familiar with this. So DK Crush 5 showed that the DK Crush in the left main stem had some significant evidence compared to other stenting strategies. So what do I do practically? I use this for teaching a little bit. And it's very common strategies that most people use. If there's a side branch that's a large vessel, then I treat it. Is the disease ostium diseased? Yes. Then I go for a dedicated two-stent strategy. If the ostium's not diseased, I wire the side branch, do provisional strategy, and use TAP as bailout. If it's not a large vessel, I just do provisional stenting strategy. I'm sure most of you follow a similar strategy. So it's a complex case. Tried to employ the KISS approach, but unfortunately it didn't work. But gave me a great deal of confidence as an operator, and then subsequently developed into a fairly complex operator. Patient was discharged next day, living good quality of life, and I guess the other issues are complete revas versus partial debate is ongoing, but for this patient, in this case, the complete revascularization worked well. Thank you.
Perfect. This is really complex. In Michigan now, it's actually outcome metric that Blue Cross Blue Shield will basically rank us according to IVUS-guided PCI in the left main and for stent failure. Did you guys did you use IVUS? Okay.
Yeah, so I used IVUS for the left coronary artery, not for the right coronary artery.
So the other question, why, like, this is, I agree with your strategy, but I cannot want to understand, it looks like the culprit is the left main when the patient presentation, right?
Yeah.
And I agree with your strategy, so treating the RCA, but I cannot disagree with your strategy of sending him home and for medical therapy. Like, you should probably treat the low-hanging fruit and keep going in 2 different sessions in the same session, but I wouldn't send that patient with left main home. It's like,
no, I agree with you. I think we were hit by a couple of things. One was the patient wanting to go home because he wanted to attend his wife's funeral. So one option was to bring him back for a stage procedure in a few weeks' time. But as it happened, he had ongoing symptoms.
Yeah, no, fantastic case and congratulations. I think one of the things that I really harp on our fellows about is when you send a patient like this, he's 86 with Parkinson's for a surgical evaluation, and the surgeon accepts that patient, is that something that's acceptable to you? And a guy that has really no LAD target for a lima, he's 86 with Parkinson's. I mean, you know, I know we have to do this multidisciplinary discussion, and I get it. And I certainly value the opinion of our surgeons, but sometimes when they would, if they would accept a patient like this, I'd be worried about the patient.
Yeah, no, I completely agree with you. I think it's in the UK, the system is a little bit more conservative compared to North America. We do need to go through the approach of the MDT, and if they get turned down, then we get licensed to essentially do what we want to do. It's just doing ad hoc PCR on this patient without discussion would be frowned upon in case of a complication.
So a couple of comments. I agree with the fact that you had the discussion. I have a similar practice set up in Canada as well. We often pause to discuss those cases, and certainly with those variables being in his 80s and Parkinson's, probably we would lean towards PCI, but we still have the discussion. I wanted to point out the strategy of potentially doing an intervention and then staging is not necessarily wrong in this case, but I do think just personally the culprit was that distal left main and the LAD. So I think in reality, if you had gone ahead and dealt with that, you might have gotten away with the staging of the right, you know, at a later setting. I think it's just more so that the critical lesion was in the left system, but also excellent work in general on the PCI.
Yeah, and I completely agree with you. I think one of the concerns was we don't have impeller and we don't really have too many support systems. So if we were doing the left main, we didn't know how he was going to behave. And if we decompensated on ballooning of the left main, we just thought doing the right would give him some more support.
Did the AVIS show calcium, or was it thrombotic in terms of the mechanism of the ACS if we think the left main was the culprit?
So a little bit of both, actually. It was morely calcium in the left main, but it was thrombus in that LAD, which was subtotally occluded.
Great, thank you.
Thanks.
This is a highlight, really, this case highlight something I'm passionate about, complete revascularization. There are a humongous amount of data now. Of course, as STEMI is no discussion about it. You always have to perform complete revascularization, but in non-STEMI, that also, there are data up to 36,000 patients from the VA system. There are 55,000 patients that shows you need to complete revascularization, and in a stable ischemic heart disease also. So you guys like have the fellows and the audience need to take from this, like complete revascularization in 86 years old, definitely better quality of life after that. And you have to treat the culprit lesion. Thank you so much, Rahul.
Thank you.
Appreciate it.
Next up, we have Dr. Ahmad Awad with Protruded RCA Ostial Stent. How to manage.
Hello, good morning. It's a pleasure to be in here. I'm Ahmad Awad, Al-Azhar University, Cairo, Egypt. Our case is Protruded Ostial Stent, how to manage. So we have this female patient, 58 years old. She's diabetic hypertensive dyslipidemic. She had a past history of PCI to left main LAD with LCX mini crash technique. Currently, she was complaining from recurrent attacks of chest pain. Her ECG and echo were unremarkable. So the coronary angio showed the following. The patient had in-stent restenosis in the left main with RCA lesions for CABG, but the patient refused CABG. So she was prepared for IVAS and drug-coated balloon for left main and DES for RCA. Starting with the RCA, single long stent versus two short stents. I choose two short stents, starting with a mid RCA lesion, fix it, accepted result. Then ostial positioning of the ostial RCA stent. Unfortunately, the patient took a deep breath, so the stent was slipped in during inflation. And I have missed the ostial lesion, and this lesion was hazy, so IVAS was used. The IVAS showed that we have a hazy lesion in the ostium most probably dissection from the proximal edge dissection of the proximal stent in a significant atheroma. So, and the stent was not well deployed. So this was the chromo map to show the dissection, mini dissection. So another stent was used in the ostium. It was inflated, the overlap, then flaring the ostium. Unfortunately, the stent was stretched because the guiding catheter was not supporting, and it was away from the ostial stent, and it was not coaxial. Another reason that this stent is well known for longitudinal deformity and the connection of the struts is weak. Long part of the stent protruded into the aorta. It was obvious here with non-selective injection. IVAS had made the confirmation for the long part of the stent inside in the aorta. Here, the protruded segment. It was too long. It was measured by IVAS landmarks to determine the length of the protruded segment of the stent inside the aorta. So we could see here also in the echocardiography in the parasternal long axis toward the right coronary cusp, it's floating here. And this is a stent post to see the segment. And this diagram to show the length of the protruded segment of the stent in the aorta. So I have to deal with. The options were to leave it with high risk of thrombosis and cerebrovascular stroke in this area, or to crush it with ostial flush balloon, which was not available, or to snare it. So I decided to snare it. Snared here, then here, then back safely inside the guiding catheter. So this was the stent with the snare, EN snare. Back again to the RCA. Rewiring using umbrella handle curve to ensure to be inside the two stents, not substrates, which was advanced distally successfully. Then another stent, hopefully no new problems in this area. Inflated with coaxial catheter near the ostial stent and fixed. So inflated, overlap, ostial flare, IVAS again, post-dilatation in the mid-segment RCA and post-dilatation in the ostial stent. Here optimization here again, and ostial flare. Accepted results. This was the final results. So the key point for the operator and team in this situation to prevent this problem, use multiple angiographic projection before deploying the stent. Ask the patient to hold his breath or her breath while deploying the stent. Use the ostial pro device or Zabo technique to optimize the ostial lesion and ostial stenting. The inflator should be prepared and connected to the stent so that inflation can occur immediately when the stent position is optimal. And solution inflate a short 6 to 8 millimeter length oversized balloon to flare the overhanging protrusion of the stent, and from the start to well preparation of the lesion by a balloon. Use the ostial flush balloon. Consider prolonged dual antiplatelet therapy. If the stent procedure more than 50% out of the ostium, it is sometimes possible to snare and remove it, although this maneuver carries the risk of coronary injury and or stent embolization. Thank you.
Perfect. Thank you for. So, do you know why this happened?
I think because the lesion was not prepared well with pre-dilatation with a balloon. If we had prepared it, I think the problem will be minimized.
But also the kind of a stent, Promise is a terrible stent.
Yes.
For longitudinally, it's actually, I've seen the balloon, someone trying to go with the balloon into the side branch in a diagonal, and the Promise stent got pulled into the side branch.
Yes.
Unbelievably. terrible. And for ostial lesions, I normally do not use the Promus or its cousins, whatever it is. It's I use like it has to be really very good longitudinal compression. So let me ask you this: for ostial RCA. So Ostial Pro, you mentioned Ostial Pro and the Zabo. Have you ever used the Zabo technique?
No, I never used the Zabo technique. Even Dr. Zabo himself.
I don't think he used it either, because I tried to use it and it did not work.
Yes, it's a little only.
I'm going to ask the panelists. So Ostial left main, Ostial RCA. What's your technique to deploy a stent?
Well, so first of all, in these ostial rights, I'll just go with that. Your view, you need to be really far LAO, like 35, 40 degrees sometimes straight LAO, to make sure that you've got the ostium. If you're really concerned about where exactly that ostium is, you can put a second wire in the cusp and allow it to prolapse in the cusp to mark it. If there's a lot of pistoning, I mean, you imaged it, there wasn't a lot of calcium or anything there. So if in those scenarios, I will direct stent to avoid a lot of the back and forth pistoning that you may have in what becomes a moderate lesion after you pre-dilate it. So those are some of the tricks that I employ for ostial lesions, but a lot of it is the view.
How about left main?
Yeah, for left main, LAO cranial is really the view, and then using a lot of those same strategies.
So I would echo what was just said. I mean, getting multiple views is very key, and as was mentioned for the left system, I make sure I've had a good look in cranial views. For the right, just recently in particular, I've started using that wire in the cusp trick, and it's somewhat helpful, but I think you have to still be cognizant of other factors as well, and it's not like 100% perfect way to do things. The other thing to remember is that you can get your patient to cooperate with you too, so if I'm really struggling and there's a lot of that to and fro movement, I give them a heads up, okay, I'm about to put your stent in. I need you, when I tell you to, just stop breathing or don't take big breaths, don't make sudden movements just for a few seconds, and I'll tell you when you can relax again. Yes. So sometimes that really helps if things are just flying back and forth.
Yeah, I think, echo what everyone has said, certainly for the RCA, LAO caudal, steep, mag-in, columnators, and the cusp, a wire in the cusp is something I've started using, and it's helped tremendously. Zabo, I agree, I've tried it, but it's just put a wire in the cusp.
This discussion highlights the fact that we don't have a good solution for ostial stenting, so it doesn't matter how good you are. I mean, all these techniques are great, and I have good results most of the time, but all of us have been where, the stent is too far in or too far out, it's going to happen. Right. This is why ostial flush really is a nice solution. And if it is available to you, then you won't worry. You'll bring the stent back a little more, and then you make sure that you use the ostial flush balloon, and it really tucks that stent nicely on.
Yeah, I think the views that were articulated are the ones that I use. We'll do a decent amount of IVUS marking if it's really opaque where it is and we can't tell, and the angiogram doesn't decide it. And to Wissam's point, we'll just hang out a little bit and flash it. The osteoflash balloons are great. A couple other technical things, we have a pretty busy, complex PCI program, so a lot of times you have 7 and 8 French guides in place. The stent radial strength and longitudinal strength is something we think a lot about. So if using an osteoflash and hanging it out a little bit to protect against crushing the stent with the guide, even if we use a more resilient stent, I'll just usually hit it pretty hard with a 4.0 or 4.5 balloon, whatever the imaging tells me it should be, even before trying to get the osteoflash in, because the osteoflash is kind of stiff, and you don't want your guide to kind of be pistoning back and forth on the stent, because we have had myself and my fellows have folded the stent over, which is its own disaster of trying to get through. You have to sort of take little balloons and rebuild the whole thing. We have a pretty busy brachytherapy program, which in the US we use to treat failed stents because we don't have DCBs yet. So I often inherit these from other people, which is fun. Some tricks in terms of what guides you use, how to flex a guide in the cusp over itself, wiring them from afar, wiring the side of them. In some cases, you just sort of go through the side. If you can't get in the lumen, you just flex it up with a balloon and sort of push it up as space junk in the aorta, then put in your stent. And so there's sort of lots of points of pain with dealing with these based on whether they're acute or you've inherited one from someone else.
There is a study, actually, it's interesting. They did a CAT scan views to determine the best views to see the ostial RCA. Guess what the angulation per the CAT scan for the ostial RCA? 79 LAO.
with a little cranial on it.
And with a little cranial, yeah. 79, can you believe that? Like, there is no good way to do it.
Yeah, you know what nobody commented on is snaring that stent from the ostium, which was gutsy. You know, I mean, I would personally not have done that because you have to. I mean, you're concerned about that stent protruding with all the problems that we heard about that could lead to it. But there's a big risk of trying to snare that from the ostium of the RCA. The whole thing could shut down. You can dissect the aortic wall. You could dissect you may not be able to get back in the RCA. So. I would have personally just left it there, tried to balloon big time proximally to make it big and post-dilate and just live with it.
Question to protrude the stent. I agree with you. Yeah, so you just have to, like, the problem is just if you need to come back.
Yes.
When you need to come back, it's going to be a problem if you have to come back later. Yeah, well, like the promise will be crushed, and it will be basically the promise will be just kind of a ball in front of the RCA. So I kind of agree of finding a solution. I agree with that. Go ahead. Yeah, that's
maybe a solution.
That's what Dr. Croce said. He this will be a very simple solution.
But I would do that only like if the patient comes back. I would not do it now with a good results. You know, I would just leave that stent sticking out, and if he comes back, with such a stent protruding with such a distance, there's no way you can get back in the middle of that stent. So you'd come from the side then and crush it.
Yeah. All right. So
your guide choice in that situation is important. You want something that you can easily disengage, hopefully, and re-engage. We'll often wire through the side of the stent, back the guide up, try to point it to where it's coaxial, and then lead with a second wire that has an umbrella handle knuckle to try to find the lumen. So, you know, there's stuff you'll do before you just move to the place where, all right, I've given up. I'm just going to crush it, create a neosteum, and start over, which sometimes you have to get to, but there's some tricks to get there after trying some things that may preserve the luminal position of a wire if you can. And then usually after we wire it, we'll image it to see if we're in the right place. If not, we give up.
Or double wires. What do you guys think? That for that pistoning movement, what do you do?
Also the length of the stent, you showed a shorter length as a more problem.
Yeah, the biggest trouble in my experience, you know, systole does this a little bit. The heart moves slightly. It's really respiration, which is magnified with all of the radial PCI that we do. So if the patient is compliant and able to stop their breathing, I'll stop, wake them up, say, hey, listen, we're going to practice this breathing thing. Make them do it once, make sure they can comply. You know, deep breath in, moderate breath out, hold it, and just sitting, make sure they're holding it. And if they can do that, then you can actually try to place the stent while they're holding their breath, which is helpful.
I don't do this anymore, Kevin, because what's going to happen is you make them take a breath in, and suddenly, as you're deploying the stent, the patient breathes out suddenly. And like, I prefer just a little bit of breathing.
So,
breathe. Shallow breath is the coaching. Stop mid-cycle. It's not a deep breath in and out. That actually kicks a step back. It's I want you to breathe very mellowly and stop mid-cycle, and we're sort of, they're compliant enough. And then have them practice it, because the last thing you want to do is think they're going to do it, and then around the time you're deploying, they then take a breath because they're holding it. Yeah.
All right, guys, we have to move for the next next contestant. I keep saying next patient. Thank you, Dr. Awad. The next contestant is Abdelhamid, Dr. Ahmad Abdelhamid, a non-conventional use of Carlino trick in a device uncrossable in-stent CTO. Perfect.
Kind of a long title. I'm sorry.
That's okay.
Okay. I've no conflicting interests till now. I'm sorry. My patient is a 69-year male patient. He's hypertensive, diabetic, ex-smoker with a long history of ischemic heart disease and prior interventions starting from 2003 through 2018. This case was in December 2022. But what is relevant through this is that he has underwent lots of procedures regarding his right coronary artery. His ejection fraction is 30% with the right bundle and a QRS of 140. Started to complain of crescendo angina peaking to be with effort and tolerance over the last 3 months. That was his coronary angiogram of the left system, showing a beaded lung stenosis or serial stenosis in the circumflex and kind of tight in-stent stenosis in the metal jacket that is extending from the paraostium of the LAD to near its distality, plus a CTO of the right coronary that is filling retrogradely. The RC injection is almost an O2 ostial, except for that early conal branch. And it is an in-stent CTO. We started with the left system, treated with DCPs for the LAD and a long stent in the circumflex with an acceptable result. Then planned for a separate session for the right coronary artery. Brought the patient back in 3 months, starting actually trying to put the AL1 in the right coronary artery. A 7 French AL1 was very tempting that we had to advance a wire for stabilization into the conal branch. Then trying to advance the CTO gear through the O2 ostial CTO was really challenging, so I escalated support actively with an anchoring balloon in the conal branch. Started with a Miracle 12 wire from the outset, supported with a Croce Pro 150. Hardly the Miracle was steered through the in-stent CTO towards the distal true lumen. When I tried successively to steer the Corsair over the Miracle in order to be able to de-escalate, that was really challenging because every time I tried to torque the Corsair, it could not cross the 90 degrees bend of the in-stent CTO in the RCA. And despite all the maneuvers to overcome the poor support, this was not happening. I know this is a kind of off-label, but we tried to steer the Miracle without de-escalation all the way to the right coronary artery into the PDA in order to have better support, but it did not work. So in hope for support, I used an AL1 7 French in power position. I used a wire in the conal branch. I anchored in the conal branch repeatedly at high pressure, and I steered the Miracle all the way to the distal RCA, but still it was not working. The bend of the RCA in-stent proved indeed to be device-uncrossable in-stent RCA. So after spending kind of 40 minutes trying to manipulate it, we changed the strategy. At the furthest reach of the microcatheter, I performed Carlino. I know that Carlino was essentially and initially developed in order to modify the proximal cap to facilitate wiring. But now we made use of the hydraulic microdissections in order to modify the neoatherosclerosis at the RCA bend in order to facilitate device crossability. And actually it worked. We rewired, advanced the microcatheter, exchanged with a supportive Grand Slam wire in the PDA. And with the escalation of ballooning, starting with a 1.2 balloon, we were able to deploy the 3 stents and get off with an acceptable result. We have lost to the RV branch, but luckily that it was very well collateralized from apical LAD. And the learning points were in-stent CTOs can have very tough resistant neoatherosclerosis, particularly at the vascular bends, if proved to be device uncrossable, like when the wire crossed to the distal true while the microcatheter is unable to advance. A bailout in-stent Carlino can induce breakdowns in the resistant tissue, facilitating subsequent device delivery. The metallic frame of the failed stent and the overlying neoatherosclerotic tissue tend to hold the injected dye intraplaque rather than bursting it with a subintimal space and buying troubles. Thank you for your attention.
Thanks. Perfect. So did you try the balloon?
I tried balloon, but it did not work.
What balloon did you try?
The smallest that we have in our cath labs is the 1.25, the Minitrack.
Oh, okay.
We do not have Sapphire these days.
Yes, I find Sapphire very, very, very helpful. Very, very nice solution for this. And So
did the balloon not soften it, or did it not open? When you ballooned it, was the balloon constricted, or it wouldn't cross?
Actually, we tried just to advance a balloon and planning that we can have granuloplasty, but the problem is I was in danger to lose the whole system. So I was trying to be very wise, pushing or trying to wedge the balloon was endangering that I have the wire and the guiding getting out.
Great. So effectively, it was a very challenging in-stent wire across gear wouldn't go scenario, correct? So you tried granuloplasty, didn't work.
Granuloplasty could not deliver the balloon to the point that the microcatheter was struggling to cross. The microcatheter advanced better than the balloon.
Do you have different microcatheters to try, or are you limited to a few in your center?
Actually, I used the same microcatheter. I have other options, but for the limitation of resources, opening 2 microcatheters for a case that I'm not guaranteeing the final success would have been an issue.
Great, because that's also, change your microcatheter, maybe a turnpike spiral or something else might have been of value. The other way to support in a case like that, which is when you have the wire distal in the RCA and you've confirmed it's there, you don't really need your left guide anymore. So in a couple cases, you can take that ping pong into the ostium to the right, inflate a balloon on a guide liner to pin it in the artery, and it just allows you to shove stuff harder. So there's a couple things that can help in that scenario. But a lot of times, as you mentioned, the metallic frame of the stent, potentially at the bend of the right coronary artery fails, and there's something really evil and noxious there that you have to deal with.
It's a stent fracture.
Yeah, stent fracture.
If you have a stent fracture, nothing will go sometimes. You have to go around it. Yeah, so I think for the interest of time, we have to move, Kevin. Represent that last. Thank you so much.
Great. Our last case is presented by Dr. George Shenoda, simple start, unpredictable end. Welcome.
Good morning, I'm Dr. George Shenoda from Swag, Egypt. My case presentation is simple start, unpredictable end. I have no disclosures. My patient is 42 years old, complaining of retrosternal chest pain with exertion that was increased recently and became with minimal exertion. Patient not known to be diabetic or hypertensive. He is a heavy smoker. His ECG showed depressed ST segment in lead V1 to V6. Echo ejection fraction was 65, no wall motion. Patient referred to cath lab. Femoral axis, 6 Frenchies, coronary artery, coronary angio revealed, normal left main, subtotal LAD proximal lesion, followed by mid-segment not significant lesion, and another borderline distal lesion. LSX was normal, and RCA was diffusely atherosclerosed. So we planned to fix the proximal subtotal LAD. We used 2x20 balloon and 3x18 DS. And after deployment of the stent, we noticed that the mid-segment lesion became more prominent. So we decided to use another one, DAS 3x24, with overlapping with the previous one. And that was the final result. So the net result was good, so we decided to finish the procedure. And suddenly, after the last injection, the patient moved upright and coughed and strongly coughed, and then patient developed severe chest pain and hemodynamic collapse. And that was a coronary angio. So what happened here? We'll see. So what is the possible diagnosis? It may be acute stent thrombosis or left main dissection. It's confusing. So we start in trope, noradrenaline, and painkiller, morphine. So what to do next? Call for help, colleague with fresh mind. Try to be calm and rearrange our plan. Left main dissection was our first possibility because of sudden movement of the patient. So we decided to wire the left main LAD, and also we tried to do 2 things, not to be panic and not to inject dye. The problem was how to wire LAD. So the true lumen, as the wire always go to the dissection plane. We tried different wires, but always wire go to false lumen. So what to do next? Stop trying cold surgeon. Try bang bonk technique, but need another sheath and another catheter, try different guiding catheter. So we used Judkin Lift 3.5 guiding and Gallium wire, and after several trials, we managed to reach the LED true lumen. And this appears a left main dissection, this is the left main. So the situation now is somewhat stable. Our question now is trying to wire LSX or just do direct left main LED stenting. We decided to do left main LED stenting using 4x24 DS and both using 4.5x15 NEC balloon, and that was the final result. Sorry.
Don't worry about it. Someone has phone, like when you guys have Bluetooth, try to connect to this TV. If you wouldn't mind, just close your Bluetooth. I'm not sure. Someone phone every time try to connect to this TV. I asked the guys in the back. Go ahead, continue. No problem.
I want to back. Okay. There's 6 types of coronary dissection: type A, luminal haziness; type B, linear dissection; type C, extraluminal contrast staining; and type D, spiral dissection; type E, dissection with persistent philic defects in the coronary lumen; dissection type F, which was our one, was dissection with total occlusion of coronary artery. My take-home message: iatrogenic left main coronary artery dissection is rare but dreadful condition. Its rate is 0.1%. It is the result of mechanical trauma of the arterial wall during coronary artery instrumentation and manipulation, leading to separation of the media by hemorrhage that create a false lumen with or without intimal tear. Timely recognition of the dissection and construction of a proper treatment plan based on the type of the dissection and the clinical status of the patient is needed to overcome potentially fatal complication. Treatment consists of maybe PCI, cabbage, or conservative, and nowadays most frequently to PCI. And thank you.
Perfect. So when you have an ostial dissection, you cannot go with an aggressive guide. It's like you can do air mailing, like you sit from outside the left main and you send the wire, because if you engage the left main, the guide normally, especially I use really aggressive guides, they go into the false lumen. We only have 2 minutes of discussion. This case brings a lot of good points. Anybody?
You know, I think it's probably minor, but with a dissected left main, I might have tried to get a wire into the circumflex. The way I would do that would be, if the wire in the LED is certainly in the good place, is to take a dual lumen microcatheter down into the LED and then drag it back and pop it into the circ. That would just be one other thing I thought of as I was watching you work, but you got away with the direct stenting left main LED with no impingement on the circ. So good call, it worked.
And do you have any form of hemodynamic support in your lab, balloon pump?
Yes, we have an intra-aortic balloon pump.
Yeah.
But after we lift the patient without injection, he becomes more stable because the staining is removed after a while, so we don't need it. We use only inotropes. We use the noradrenaline only.
Yeah, it's just norepi. Yeah, no, sometimes, you know, with your inotropic meds, everything becomes a little bit more difficult. They become more tachycardic. It becomes even harder to wire. But yeah, I think, you know, just get a wire that you're very comfortable with and try to find that true lumen. And you really want to get a good loop on it once you get into that LED that you've stented, so it's not behind the stent strut, because I don't know if you've IVUS that to make sure it's opposed.
We use the balloon to be sure that we are in the true lumen.
Oh, okay.
Or you can do orthogonal. Any other point?
There must have been some, when they were trying with the JL, there must have been some recanalization of the lumen. Otherwise, I mean, patient would have died without being on ECMO, just being on pressors. Because the whole left main was shut down. I mean,
yes, I said that after we stopped injecting dye, the flow to the LED was improved. Yes.
We're done. All right. We are at 10 o'clock. Thank you so much. These are great cases. We're going to score here, and I'm not sure what's going to happen about the BMW after that. We need to pick 2 top winners. Thank you so much, guys.